You can start the session now, sir.
A very good evening, dear doctors. A very warm welcome to another episode of Anubhav, an experience sharing by experts, wherein we bring the stalwarts from the field of infertility to discuss difficult to treat cases of infertility. And today's focus is on the repeated implantation failure. But before we move on, let me take you through the brief journey of Justiva mankind in the Indian pharma industry. Dear friends, with humble beginning in 1995, Mankind Pharma is among today the top 5 fastest growing pharma companies, with number 1 rank in terms of prescription and 4th in terms of top line revenue. In 2021, Mankind launched its dedicated gynecological division, Justiva. Justiva is committed towards innovation and developing new therapies in the field of OBGYN. Over the years, we have represented ourselves in almost all the major therapeutic segments with leadership position in many. We are among the top 5 anti-infectives, gynecological, women healthcare, gastroenterology, cardiology, and diabetes. We've also been working upon innovations in formulation and dosage forms and drug delivery. One of the main factors behind our success for being the fastest growing pharma company is an operational excellence and strong supply chain, which enables us to reach to the highest coverage of 600,000 pharmacies and 400,000 healthcare providers. In the last couple of years, Mankind has made significant footprint in the full field of research and development. Mankind's R&D center is located in Manesar, Delhi, NCR. This state-of-art research facility has a dedicated team of over 600 scientists involved in complex and innovative research. Some of our clinical research and biopharmaceutical capabilities include new drug discovery and research, advanced pharmacokinetic modeling and biostatics, formulation and development of clinical research. Mankind's new drug discovery research and pipeline includes target for NASH, arthritis, diabetes, and we are happy to share that recently our novel GPR119 agonist for diabetes mellitus has shown better glycemic control over sitagliptin in animal trials, and the molecule has now entered into phase 1. Anubhav Case Series is an educational initiative for Drogyna, a brand of dydrogesterone. Let me have the honor and privilege to introduce our speaker of this episode of Anubhav, Dr. Sheetal Jindal, a senior fertility consultant at Jindal IVF. Dr. Jindal has fellowship in ART and a co-convener of SIGA Applied Genetics. Dr. Jindal has more than 12 years of experience in IVF and high-risk pregnancy. She has published many papers and has been invited as a faculty in regional and national conferences. Dr. Sheetal has special interest in infertility, peri-implantation, genetic testing, hysteroscopy, to name a few. Before I hand over the session to Dr. Jindal, I request all the attendees to post their questions in the chat box and comment sections. With this, I hand over the session to Dr. Sheetal Jindal for scientific proceedings. Over to you, ma'am.
Thank you, Ashutosh. So I would not waste much time and I would straight away go for my screen sharing. Okay, so is my screen visible?
Ma'am, it's coming up.
Okay.
Ma'am, it's visible. Please make it on slideshow mode.
Yeah. So, dear friends, my colleagues, my seniors, and whosoever is watching this session, I welcome you all. And it is a privilege, and I thank you, Mankind, for giving me this opportunity. And I would try my best to, contribute to knowledge of each and every one of you. So today I bring you a case of repeated implantation failure. So I start my case. She's Mrs. Reena. I have changed the name. She was a 31 years old female resident of Panipat, Haryana. And she first visited our hospital on 8th of January 2020 with primary infertility of 4 years. And when she approached me, the couple was absolutely, shattered because they had previous 3 IVF and 4 embryo transfer failures at Delhi. And husband was a known case of azoospermia. That is what they had told me. Her menses were regular and they had no other history. They were tired of treatment and they had taken so much of treatment that they said, ma'am, I cannot get pregnancy through my own egg and my husband is azoospermic. So please give me a donor egg and a donor sperm. I just want a baby. Give me in any possible way. So, these are the reports which couple had brought to me. They were done back in 2017. Her azoospermia was in the ejaculate was documented 3 to 4 times. She had few hormonal tests which are always done in the preliminary evaluation of azoospermia. Her serum FSH was 6.21. Her testosterone was fairly normal. And she, I was happy that her karyotype was already done because she was a case of azoospermia and it was normal, 46XY. And the Y microdeletion testing, which probably, it is with queries whether it should have been done or not, but yes, it was done and it was absent. She did have an FNAC report in which palatal testes had shown an evidence of mature spermatozoa. And a scrotal ultrasound was done, which showed a normal testicular size, and there was no other positive finding. So most likely, seeing the above, reports, we can say that probably she's a likely candidate of obstructive azoospermia. So it is a tentative diagnosis because her FSH levels are on the normal side, and probably testosterone is also normal. And the karyotype which she had undergone was also normal. But anyways, she did not undergo any other CFTR gene mutation or something like that. So coming to the treatment history of the couple was interested, they were doubtful whether they should be using their self sperms, but wife was clear that, ma'am, I do not want to do it with my own egg. So they had initially visited to us, 3 years back also, but went to Delhi for further treatment. So these are the list of the IVF cycles which she had already undergone. Her first IVF cycle was done in 2017 with self eggs and self sperms. Sperms were obtained through TISA, testicular sperm aspiration, and she did not, however, have the details of the first IVF cycle. And she said there were 3 embryos which were transferred on day 3. There were no cryofrozen embryos available, and that result was negative. A similar IVF cycle was again performed probably at the same center. This is what she said, and it was again negative. Her third IVF cycle was done. We had the details of this cycle, which was an antagonist protocol. The couple said there were 19 eggs which were retrieved, and there were half which were fertilized with self sperms using PISA, and half of the sperms were donor sperms, and half of the eggs were fertilized with donor sperms. So out of the 11 eggs, so in total, 11 eggs got fertilized and 8 embryos were formed. And out of that, these 5 embryos were formed through the cell, and 3 embryos were formed through donor. So it is interesting to note that the number of embryos which were formed with donor sperms were on the lesser side. However, this was again, there were 2 embryo transfers out of those 8 embryos, and both were day 3 transfers, but very sadly, her result was negative. So, on an ultrasound, there was a persistent cyst which was seen, that was mentioned in her records. So she did undergo a hysterolaparoscopy for a left para-ovarian cyst, which was 3 into 3 centimeters. And the hysteroscopy was normal, and probably there was a cyst which was stretched over the tube, and it was lying by the side of the ovary, and her tubes were fairly fine. And this is and the histopathology of the cyst was a paramesonephric cyst, and the endometrium was disordered proliferative endometrium. She did undergo PCR testing because probably out of so many failures, they would have undergone this PCR testing for tuberculosis, and it was negative. So with this background, she came to our center for further treatment. So the further plan at our center was that we did a scan, and the scan showed a normal uterus. The uterus was absolutely fine, and both the ovaries showed an enteral follicular count of 4 to 5 on each side. So, I spent almost 1.5 hours with this couple, jotting down their history, listening to them. And, because they had undergone so much of IVF treatment, had moved around so much. So they, initially I was thinking, what options should I give to the couple? Because financially also, after so many cycles, it is a big financial burden also. And along with that, it is like, when I always talk to patients, I always tell IVF involves all the 3 things: time, money, and energy. And this couple was deficient with all the 3. They were very, very keen. They were just saying, ma'am, it should be our final cycle. We have come with a lot of hopes to you. we just want a pregnancy. Please give us pregnancy in any way. We don't want to use our eggs and our sperms. I think, they are useless. I mean, these were the lines, they had come with their father. The father did not speak a word for almost good 1 hour, which I had spent with them on their first visit. The wife was saying, the only wife was speaking, and she was like, ma'am, we just want a baby and please give us one baby. And the second criteria was, we do not want to use our eggs and sperms. So anyways, after listening to them, even I was a little taken aback, what should I do? So, I discussed with them. When I did the scan, and I was finding their uterus and ovaries very good. So, but then, and heart to heart, I was thinking that, why, this couple is very adamant that, I don't want to use my own egg and my own sperm. And so, what should I agree to her? Should I give a donor egg and a donor sperm? Or should I discuss some other option? Because at this point of time, when the couples, this is also very important counseling, when the couples are so bereaved, you want to help them in the best possible way. And sometimes if you start giving your own suggestions, they might feel bad, or they might not, just stick to the treatment, or they might, you are in a fix. So I gave them various options. I said, if you are financially really burdened out, you can try an IUI with donor sperms, which they said, ma'am, after which they completely refused, because they knew that the success of IUI is always lesser than IVF. And the second, I agreed to them, okay, if you're that, sure that you want to use donor egg and donor sperm, I'm ready for that. And thirdly, very subtly, I said, if your ovaries are not that bad, you can always try with self eggs and sperms, which can be obtained surgically. So anyways, the couple, hearing my discussion and all, the couple went back and did not turn up for 6 months. I thought maybe, because I gave them an idea of IUI and self eggs and self sperms, maybe the couple has not liked it, and that is why they have not turned up. So anyways, they came after 6 months, and I was happy to see them again. And they had come with the decision, no, ma'am, we want to undergo an IVF with donor egg and donor sperm. At that time, she had come to me in the mid-cycle, and definitely I had to assess her endometrium, which was pretty good. And her mid-cycle endometrium was 8.1 millimeters. So I did do further evaluation. I advised all the necessary tests before IVF. And, these are few of the positive tests which were there. The HB electrophoresis of the wife by HPLC showed HbA2 of 3.7, and her husband's HbA2 was 3.3. So a suspected thalassemia minor in both the couples, was to be done. That would have further complicated and added to the cost. But anyways, I did not do the sequencing because they were keen on using the donor egg and donor sperm. Meanwhile, she was diagnosed. She was continuously losing weight, and we thought, what is the reason? And her TSH levels were very, very low. And she was diagnosed to have hyperthyroidism. And on evaluation with an endocrinologist, she was diagnosed to have a benign thyroid nodule and was put on neomorphazole. I'm sorry. So I did do her RIF workup, which included an EPLA and thrombophilia testing, along with the karyotype. And her beta-2 glycoprotein levels were on the higher side. And her AMH was within the normal range. It was 3.01. So I did mention to that. So when I met this couple on this during this visit, I did mention to them that you can still think of, using your self eggs. But during this waiting period, the couple, visited me 3-4 times, and they were changing their decisions. Probably they were gaining a little confidence, or, slowly things were getting sorted out for them. So they opted for, they finally said, ma'am, I want a donor egg, but I will try to use self sperms because mine is she was very intelligent. So she said, yeah, I know that it is obstructive azoospermia and my sperms can be obtained. My husband's sperms can be obtained. So probably we'll like to undergo some surgical sperm retrieval. So again, that time I said, if you're using self sperms, why not try your own eggs? I mean, you can try. Probably with some confidence, I tried to, tell them. And then they took again 1 more month and they finally agreed that, ma'am, we'll use self eggs and self sperms. And then, it was a little challenging for me, but then I was very happy too. So we did the beta globin gene sequencing of the husband to rule out thalassemia in one of the partners, and it was normal. Meanwhile, wife's hyperthyroidism persisted. She was diagnosed to have Graves' disease. She was continuously in touch with the endocrinologist. And, she was again put on neomercazole that she continued, and her TSH levels came within normal limits. And an andrology consultation was taken for her. They decided, and a PISA was decided because she was a case of obstructive azoospermia. The andrologist did examine the patient physically and said, probably we can take PISA. But because previous PISA sperm retrieval was a failure, we had already discussed with them that you might end up having a micro-TZ as well. So in November 2020, her IVF was planned with self eggs and self sperms. So I decided a long protocol for better oocyte recovery. It is said that with a long protocol, probably, the M2 oocytes are better. So I got 10 M2 oocytes. We did PISA as well as micro-TZ. Sperms were retrieved. So we processed the micro-TZ sperms because micro-TZ sperms sometimes behave better as compared to PISA sperms. In fact, this is one of the questions and I would like to answer it a little later on. And post-wash TZ sperms gain motility. And we did ICSI and we obtained 5 grade 1 and 3 grade 2 embryos, which were cryofrozen. I wanted to give this patient a frozen cycle. I strongly believe that it gives a break to the patients from all the injections which they are taking. And plus, I did want, I did want to plan, the treatment cycle further with her. So patient agreed, and she was very categorically clear, and she had mentioned to me that she wanted a single blastocyst transfer and she did not want twins. So yes, we, after maybe 2 months, so in May, so, I did a replacement cycle for her and with, a replacement with estrogen. And after that, an embryo transfer was done. It was a single blastocyst transfer, which was 5AA. And her beta HCG came out to be 927 and she was pregnant. So I followed up the whole pregnancy. And her NBNT scan showed bilateral choroid plexus cyst, for which she was counseled. And she was shifted to, propyl thiouracil because of the pregnancy and due to her hyperthyroidism. Fortunately, she did not develop any IUGR and any hypertension throughout pregnancy. Very unfortunately, she had developed mild COVID towards the end of the pregnancy. But then she tided over it very well. And she delivered a baby boy of 3 kgs by elective LSCS. And she was very, very happy that I got my own baby. And the baby is hale and hearty till date. So this is, how this whole case was. So, so what I want to tell everyone that IVF is a planned procedure. So thorough evaluation of the couple is an absolute prerequisite before starting the stimulation. Like in this case, she developed Graves' disease. Husband and wife. Probably we had a suspicion that, maybe, because it's a planned procedure, thalassemia screening, I would say is a must in every couple. And if you have suspicion, gene sequencing of the beta globin gene must be done. That is very important. And obviously, change of gamete or use of donor egg or sperm is not the answer for every IVF. one failure does not mean that we should go on changing eggs and sperms. We should be very clear that, why we are changing, the gametes. Cryofreezing is must if extra embryos are present. Like in the first 2 IVF cycles, probably just a transfer was done and there was no cryofrozen embryos. It definitely, one extra cycle of IVF definitely costs a lot to the patient, and cryofreezing is something which definitely reduces the cost of IVF. And hysteroscopy is definitely not required before every embryo transfer procedure. This should be almost totally stopped. Para-ovarian cysts, yes, and laparoscopy, we have to be very thoughtful whether they really need it or whether, a laparoscopy should be done in every RIF patient. Maybe the doctor did it thinking that probably, they wanted to do a hysteroscopy. They just wanted to see what that cyst is. So they just did it, in this case. Surgical sperm retrieval is an art and it should be very carefully practiced. Your embryologist, your andrologist who is doing the surgical sperm retrieval, the urologist who is doing at your respective centers, he should be patient enough to take out the sperms once they are doing micro TZ, and your embryologist should be able to handle the sperms which they retrieve so that at least we are able to form good embryos and we can at least give them a good success rate. And, a lot of RIF cases might not be true RIFs. We must be, the patients should have a lot of confidence, in the medical practice. It should be done, properly. And, like in this case, probably, we have to, all I want to say is donor, egg and sperm is not the answer in every case.
Thank you very much, Dr. Sheetal, for such a wonderful elaborative case presentation. So we have got few questions pertinent to the topic which you have chosen. So one thing is that ICSI has revolutionized the infertility due to obstructive azoospermia. And there are different techniques like TESA, PESA, or maybe MESA. So these are commonly used retrieval approaches. So they're quite complicated procedures. So which one is preferred by you and why you go for a specific technique?
So I think, micro TZ has revolutionized the surgical sperm retrieval. And so there are various procedures which are available. So it is very clear that for obstructive azoospermias, definitely, we can just retrieve sperms through PISA. Basically, in obstructive azoospermia, the andrologist will go above the level of obstruction, which is their hands. It is the andrologist's hands or the urologist's hands. They palpate, they are able to see where exactly, which is the right place, where they should put in the needle. In PISA, they just put in the needle and, through that, they aspirate the sperms above the level of obstruction. And then you can use those sperms. Usually the sperms above the level of obstruction are obtained in millions. So these are the sperms which can be then further used. So there is various other techniques also which are available. One is testicular aspiration. So it is a blind procedure in which the needle is directly put into the testes and, you take out the testicular fluid and you process it. And, that is called as TISA. It is almost not done these days because it can cause testicular damage. And so the procedures which remain now are either TZ, which is testicular extraction. So, and a further refined procedure of TZ is micro TZ. The difference between TZ and micro TZ is that micro TZ has a much higher chances of retrieval of sperms, for the reason being that you do it under a 25x microscope. So in TZ, you give a small lick and you try to take out the sperms, but then those sperms, it is a blind, it is again, you give a 3 to 5 cut, but then you're taking out the tubules, but then you're not very sure that, which tubules. With micro TZ, you can see it more clearly, more opaque, more dilated sperms, the urologist tries to pick up. But yes, micro TZ is very taxing. Sometimes it takes 1 to 2 hours, to take out the sperms, and you have to be, you have to be sure that yes, and patient enough, to perform a micro TZ on the patient, and it is done under general anesthesia usually. So, and the sperms which you take out, then, those sperms are the ones which are used. So for non-obstructive azoospermia, definitely, the reason is that the sperms are less, either the sperm number is less. So for non-obstructive azoospermia, yes, you have to go straight away to the testes. And yes, in obstructive azoospermia, you can take the sperms through PISA, or, there are various, you can just keep going from the epididymis and backwards, and maybe, wherever you find sperms, you can halt yourself there.
Definitely, that's a very skilled job, and I think there are specific centers or specific practitioners who can do it very confidently. Now, going to another part, since you have talked about usage using donor eggs. So there are multiple IVF failures are quite common that we use donor eggs. So how an IVF specialist can improve the outcomes while doing an autologous cycle? Because you have talked about a patient who is just 31 years old. I think the donor cycle should be restricted more or less to the older patients or the Poseidon criteria, or maybe Bologna criteria, whatever they say. So what prompted you to go ahead with the autologous cycle, although the patient was very adamant to do it on a donor? So what was the difference between doing a donor cycle and having its own autologous? Is there anything which definitely defines the outcome?
Yes. So what prompted me was, you're absolutely right, Ashutosh. So she was a young patient, 31 years old, with probably good reserve, whatever her cycles were regular. So, so this was one reason, for patients, it is the success that matters. That is definite. But as IVF experts and as caregivers, it is our duty that the patients should be, guided. And even if there is one or two IVF cycles which are failing, IVF is a procedure which has a 50-60% success rate. So that should not be guiding us. That should not, be a criteria that there are two failures, then it means a donor egg should be used. Yes, if it's a young patient, the reserve is good, patient is regularly, her cycles are regular. And so I think, these are fair enough, it gives us a fair, idea that, self eggs can be used. And plus, in previous cycles, what I realized was the third cycle had given me a hint that she could make there were so many oocytes which were retrieved, and she did, got 8 embryos, so which was a good number. And when I saw her antral follicle count on ultrasound was very good, her AMH levels were good. So that prompted me that, she, it's just because patient is really, really, troubled because of so many failures, she would have probably thought ki shayad mere egg se to ho hi nahi sakta. So that is what
was built into the previous consultations, because more or less everybody as a couple, people are more interested into autologous or their own baby.
Yeah, definitely. Yes.
So
yes.
that's the counseling part. And now coming to another thing, that older ovaries normally require a pharmacological preparations before initiating any controlled ovarian stimulation. So which can involve DHE or growth hormone supplementation. So when should this supplementation be started before taking any IVF cycle? And do you use it in your practice?
Yeah, so I mean, that's a good question. So accordingly, I have used growth hormone, but I have used in very, very few cases. And second thing, what you asked was?
Dihydroepiandrosterone, androgens.
Yeah. So DHEAs, yes, a lot of people have used DHEA, and it is an androgen which is, recommended. Usually, why it is being suggested is that because the life cycle antral follicles, they are sensitive to testosterone in the pre-antral stages. So once they are sensitive to pre-antral stages, so giving, and the life cycle of a primordial to pre-antral stage is almost 180 days. So what is suggested is, because these follicles are sensitive to testosterone at that point of time, so that is why with this thought DHEA had come up in a big way, that if you give them, probably the the number of follicles which are there, it will improve the sensitivity of these follicles to FSH later on. So that is why, DHEA had come, and this was, said that you should be given. But, it should be taken with pinch of salt. These days, I see a lot of prescriptions to every patient, DHEA is being prescribed, probably, which is not right. And the second thing is about use of growth hormone. Yes, it is, there are, because, in Poseidon category 4, patients with poor reserve and advanced maternal age, in these, there are few, case studies in which they have used growth hormone, and they have said that, how it works is it acts on insulin-like growth. It works as insulin-like growth factor, and the autoregulatory, factor, it contributes to the autoregulatory factors, like IGF-1 and 2 in the ovary. So it acts on those receptors. It modifies the IGF factors in the ovary, and that is how GH is suggestive of that in advanced maternal age. All these things are on the lower side. So maybe increasing, giving GH externally might help these females. Maybe it might help in giving us some M2 oocytes. And when the patient is, and there are some anecdotal case series and reports in which it has shown to be of benefit. Now, how much it acts and how much it doesn't, you have to very clearly mention to the patient that it is not 100% effective. These are just sort of a trial for you. There is no 100% recommendation, which is there that, it is going to be effective. It is a costly treatment. If you agree to it, then I will use it for you. This is how you use growth hormone.
Dr. Jindal, any experience with stem cells or maybe some GCSF factors? Have you used them?
I have not really used GCSF and stem cells. Neither do, we have tried to use PRP and in some of the patients, but with not very good results.
Okay, so we can say that it is in a developmental stage, maybe in future. Much more clinical evidences.
No, there is a lot of evidence of using PRP, like we hear a lot of, videos, but at least in this case per se, I would not say that, it is, it is like very, very useful. In this particular case, yeah.
Ma'am, just going at since we're talking about premature ovarian failures or maybe premature ovarian aging. So any experience when you have seen Poseidon 1 or 2, maybe unexpected failures or rather response when we talk about young age patients, because we are talking about this case. So there can be similar cases in young age population as well, when we have 30 to 35 age group patients coming to you with repeated IVF failure. So your approach in that cases?
So I think you have to see what was given in the previous cycle. And how the cycle was done, what was the stimulation type which was used for the patient, what type of injections were used in these patients. And that sometimes a previous failure and a previous stimulation is a very good parameter for you to decide what you will, how you would like to plan the next cycle. So according to me, if I have one failure and if I have a record of the previous cycle, that gives me a lot of information. And, obviously, if there is one failure, you learn from it. So you are very wise in, probably, that gives you an idea how the response is. And a lot of times addition of LH, I give a lot of LH, when, but it depends on which type of, it depends on case to case, but yes, sometimes addition of LH in such cases, not in every case, it depends on case to case, it helps. It helps.
Now, ma'am, there is a very specific question. What specific precautions should be taken while planning a controlled ovarian stimulation, hyperstimulation, older women and patients with premature ovarian aging to improve the IVF outcomes?
Sorry, can you say it again?
What specific precautions should be taken while planning a controlled ovarian hyperstimulation in older patients and patients with premature ovarian aging to improve IVF outcomes? What protocol do you use in your
So
cycles?
I think it will all depend premature ovarian aging, and so these are the patients in which there can be a poor ovarian response, right? So if the
Yes.
patient is advanced age, or it is an ovary which is like an aged ovary. So in these cases, we want to retrieve the maximum. So it depends if you are able to sometimes addition of LH in these cases helps. And usually, I prefer to give an antagonist protocol, because if you're giving a long protocol in these patients, sometimes you suppress the ovaries all the more, and the stimulation which you give is for a little longer time, and you might end up getting less number of oocytes. So in case the AMH is low and it's an aging ovary, an antagonist protocol with addition of LH, usually in the ratio of 3:1 or 2:1, and you should use recombinant preparations. You should use recombinant preparations. This would be my suggestion. And sometimes, and you have to counsel the patient well. You have to tell the patient, yes, there is a poor ovarian response. There is an expected poor ovarian response. We might not, a general counseling which I give is that there is a 20% loss at every step. So let's say if you're like on day 5 of the stimulation, you have given the patient the injections and you're calling on day 5 for a scan, and you see maybe there are just 3-4 eggs, 3 on one side and maybe 2 to 3 on left side. So it is less than 6. So if that is, so there is a possibility that, once you're doing a pickup, there is going to be a loss at that point also. And, further when you go to day 2, then there is going to be a loss. So the patient might end up having just 1 or 2 embryos at hand. So in such patients should be counseled well in advance that, yes, or the second option is, depending on one cycle, how it has behaved, embryo pooling is also a very good option. So you do one stimulation, you take out the eggs, make embryos, and then you do another stimulation and you pool the embryos together and maybe take the transfer later on. And in those scenarios, a lot of times you're able to give a blastocyst transfer to the patient.
Ma'am, just a curious question, because when you're saying about frozen embryo transfers, but when we weigh the benefits and risks, so do you think that nowadays we are very much inclined to do frozen embryo transfer, whereas there are certain possibilities of fresh embryo transfer might have its own benefits?
So to be very honest, Ashutosh, we are almost doing all frozen transfers. One is the convenience of the patient. Okay, so patient's convenience, you can say probably it's a little waiting time. So some patients, might not like it. But yes, it is very clear nowadays, frozen embryo transfer success rates are better, because the reason is in fresh cycles, sometimes a premature progesterone rise or high progesterone levels by the end of the stimulation on the day of the trigger might lead to endometrial advancement. Now it is very, very clear that, if the progesterone is high, then a fresh transfer should not be done. So this is like one thing. And yes, frozen embryo cycles are better hormonally managed. So, from these two perspectives, and plus it gives a break to the patient from a lot of injections. So these 3 reasons I very strongly take, and so probably most of the transfers which we are doing in our center are frozen cycles. Fresh transfers, yes, they have a place. Any patient, if it's like, there are few patients who opt for, but in case, even if I have 2 embryos and I see there is a progesterone rise on the day of the trigger more than 1.5, so I would freeze even those 2 embryos, and I would prefer a frozen transfer only.
Fine, ma'am. And now going to the last question, are there any specific advantages if the premature ovarian aging patient embryos are cultured to blastocyst stage rather than if they're transferred at a cleavage stage? And any specific advantages you see with PGS or PGT or PGTA in these patients?
So, I think PGTA is something, I think we keep it aside for the moment. But then if you are saying a blastocyst transfer, so I think I am doing most of the transfers are blastocyst transfers only. So for, we do day 3 transfers, but then if you are really short of embryos, let's say patient has, just 2 to 3 embryos on day 2. And, and I want to keep 2 embryos, and I'm sometimes afraid that, we might not be, we don't want the patient to get disappointed. So day 3 transfers, and maybe it is a first, first means for me, it is most of the times it is a blastocyst transfer, to be very honest. But yes, in few patients, in case it is a fresh transfer, I take the embryos to day 3 and I do a day 3 transfer. But yes, it differs from doctor to doctor and center to center. A lot of doctors, what they do is they give a first cycle of day 3 transfer. And in case it is a failure, in the second frozen cycle, they take the transfer from day 3 to day 5, which is an added. If the patient conceives with day 3 transfer, it is fine. But if the patient is not conceiving with day 3 transfer, yes, they move to day 5 in the second frozen cycle, and maybe that helps. And it all depends on whether you are giving a day 3 or a day 5. It does depend on the number of embryos you have at hand on day 2. That is also one very important criteria. If like uterus is the best incubator, I would say. So, if you have dearth of embryos, maybe you try keeping them inside. You should tell the patient, okay, I'm doing a day 3 transfer. I mean, if you want to take it, you can have a good discussion with the patient, and, maybe the patient can decide.
Thank you very much. I think we have a very detailed discussion about the case and the other areas.
Yeah.
So before we close the session, I would request if you have any closing remarks.
Ashutosh, I just wanted to, tell something about PISA and micro-TZ. So like in this case, something for micro-TZ I want to say. So micro-TZ is a procedure which is an art, and it should be performed very clearly in non-obstructive azoospermias. And like in this case, we did PISA as well as micro-TZ. We retrieved sperms on both. So somebody would like to ask you that whether, which sperms did you use when you were, making the embryos. So one important thing is there that PISA sperms are lying there for a very long time. So, just above the level of the obstruction, PISA sperms are, there. They cannot come out, so because of the obstruction. So sometimes the ROS levels of the PISA sperms probably are high, and they might have high DFI too. So in this case, because, her previous sperms were obtained by PISA, so we thought that, and the patient did not conceive. So we did go, further down. We did go to the testes and we tried obtaining the micro-TZ sperms. And with that, the quality of the blastocysts which we got were very good. So this is also something very important that, so we have to, individualize every case, and, just that is how we should go about it. And also, the micro-TZ sperms are immotile. Sperms gain their motility once, they reach the epididymis. That is the place where sperms gain their motility. Micro-TZ sperms are immotile. So your embryologist has to be very intelligent, and sometimes it is difficult to check whether the sperms obtained from micro-TZ are dead because they are immotile. So, you have to be very sure that, yes, these sperms are alive before you take them for ICSI. So if they're head and tail, and each embryologist has his own ways. There is HOSE, hyposmotic swelling test, probably, and there are, every embryologist has their own ways of checking whether the sperm is live or dead. Our embryologist, what he does is he will, check, he will try to, fiddle with tease the tail of the, sperm. So if the tail and the head are moving separately, probably that sperm is alive. And if the tail and and the head are moving together, then it means that sperm is dead. So the sperms in micro-TZ, we have to be very sure that the sperms are alive. And those sperms, you tease them, whatever tissue in micro-TZ, you get the chunks out of the testes, and those, the tubules, they have to be teased properly. And you have to take out the sperms. and then you have to centrifuge them, and then use those sperms for ICSI.
Understood,
So
ma'am.
I think so. This is a it has to be done very, very properly, so that the patient is able to get the results.
I think it's a very fascinating and difficult task at the level of embryologist. And,
as well as
thank you
urologist too. Yeah.
Okay, great. So great to know, ma'am. Before we close the session, I think all the attendees have joined us for this beautiful discussion, and we will be bringing you more such cases in the future. I thank Dr. Sheetal Jindal for such an elaborative talk and discussion which we had post the case presentation. With these words, I thank each one of you. Thank you very much. Have a great good night. We wish to see you soon. Thank you very much.
Thank you, Mankind, and thank you all the participants. I hope I could, answer all the queries. If there are any specific questions, please, you can always let me know, and I would be very, very happy to answer. Thank you, Ashutosh, and good night, everyone.
Pleasure here.
Thank you so much. Thank you. Thank you.
Ruchit, we can close the session over here.
Okay, sir. Thank you, sir.
Thank you, madam. Thank you very much.
हाँ जी, क्लोज कर दिया?
हाँ जी मैम.
कुछ क्वेश्चंस थे भी, मुझे तो लगता नहीं कि कोई क्वेश्चंस थे.
मैम जो फेसबुक है वहां से थोड़ा सा आता है, so what I will do, ma'am, since we would like to answer them because Facebook has a lead time, so I will drop this few questions on your WhatsApp. If you don't mind, you can answer those in text format, and then we can post it on the Facebook itself, ma'am.
Okay.
Because Facebook audience is totally different.
Okay. So otherwise it was okay? I mean...
Yes, fine, ma'am. Good, ma'am. You had explained all the top pointers very prudently, and have also gone specifically on POA, premature ovarian aging, because recently we had one product, Overflow Q10, which has been launched. It's a combination of
Okay,
DHEA
so Q10 का तो है. I didn't speak on that. आप पहले बोलते.